Today with us very eminent panelist, as was rightly pointed by Dr. Mishra. Dr. Jose Chacko is Senior Intensivist and HOD Critical Care at Naran Health, Bangalore. Dr. R.K. Singh is Senior Intensivist and Head of Critical Care and Emergency Medicine at SDPGI Lucknow. Dr. Pratibha Dilip is Senior Intensivist from Ahmedabad, and Dr. Sumit Ray is HOD Critical Care and Deputy and Medical Director at Holy Spirit Hospital, New Delhi. So with that,
Thermally, Dr. Bhalla has joined, but probably not able to get connected, but he is there on panel.
Okay, so if internet permits, we'll have also Dr. Ashish Bhalla. He is a senior professor and of internal medicine from PGI Chandigarh. He may be visible soon. So waiting for him, and I again welcome you all. We'll be discussing about heat stroke in ICU because India is a country is known to have tropical climate. And every year, for a period of around 3 to 6 months, it varies from year to year, we get a heat waves, which that peak temperature reaching up to the tune of 40 degrees or sometimes 45 degrees in different parts of the country. In my home city, Bhubaneswar, recently the peak temperature has been 43 degrees. So if you look at the global statistic, at least 1 person in 7 suffers from heat-related health issues. And when they present to the hospital and the need arises for ICU admissions, morbidity and mortality goes high. It's not only short-term acute morbidity and mortality, also the long-term sequelae and the complications take a toll on their health and finances. So we'll see how we go about it in the next 45 minutes. And just share the screen to, it is visible, I hope.
Yes, it is.
Yes, okay. So in this respect, recently a seminar and a global summit has been concluded in Africa named as under the project of Chilling Prospect 2022, where they have looked at how to bring down the suffering of the people of the global populations due to extreme of heat.
Emily, you need to talk little louder. Your voice is very low.
Is it better now?
Yeah, now.
Okay, I'm coming close to it. Okay. So this Chilling Prospect 2022 has been recently concluded in Africa, where they have looked at remedies to bring down the suffering of people from extremes of heat across the globe, and many plans have been envisaged in these directions. So these are the learning objectives of today's session. So going with this, I'll just share a case history which was in actual case, it was in our ICU pre-COVID times though. She was a 24-year-old lady, primary gravida, no comorbidities to note, and was primarily treated outside, apparently uneventful antenatal period. On 15th May, she had labor pain, which started around in the evening at almost full term at home. She was taken to a labor room in the district level hospital, which was covered by duties of an obstetrician there. There was non-progress of labor for entire 16 hours, and oxytocin was started to augment the contractions. Rupture of amniotic membranes happened with loss of amniotic fluid in due course of time. And LACS, that is cesarean section, happened only on the next day at around 11 a.m. So to note that there was a gap of almost 13 hours between the onset of natural contractions and delivery of the baby. It was also followed by mild postpartum hemorrhage, which was managed with oxytocin and blood transfusions. Baby was large and had aspirated meconium due to the prolonged labor. So 1 unit blood was given during the cesarean and second unit was given subsequently. During the second transfusion, she developed actually high grade of fever, and she had altered sensorium as well and started developing breathing difficulties. There were no witness seizures because that first thing comes to mind for pregnant ladies with the altered sensorium and breathing difficulty. And then both the mother and baby were transferred to our hospital for further management. Now at the emergency department, she was found to have having altered sensorium. Temperature was 106 degrees Fahrenheit. Pulse rate was 180 per minute. Sinus tachycardia. Blood pressure was preserved. Saturation was also preserved on room air, but she was badly tachypneic with 48 rate per minute. There was no signs of distress though. And this is the blood gas. If you see, there's a severe metabolic acidosis with lactate of around 6 and base deficit is there. So with this and base deficit is of minus 16.2. So with this background, I would like to ask Dr. Sumit, what will be your first diagnosis for this lady with the background?
Well, in this setting, first of all, I would
think of obviously a sepsis, prolonged, labor, and going in for a cesarean, district hospital, high-grade fever, I would obviously keep the woe of a puerperal sepsis in mind, with multi-organ dysfunction, with metabolic acidosis, hyperlactatemia due to hypoperfusion, etc., associated problems. So that would be my first actually. Having said that, the possibility that this high grade of fever, two other possibilities we have to keep in mind is this patient underwent a cesarean, maybe under general anesthesia, we don't know, and in a district setting where the possibility of using halothane and succinylcholine is a possibility. So malignant hyperthermia would be the other. And the third would be heat stroke, depending on the ambient temperature, which was there during the whole process of her labor and her cesarean section in the OR. So these would be the three things that I would be looking at.
Right. So at the emergency, so as you rightly said, the first and foremost diagnosis that comes to mind with the given background of this lady is puerperal sepsis. There will be definitely suspicion for having embolism, either amniotic fluid embolism that comes late though, or the pulmonary venous thromboembolism or transfusion reactions because it developed during the second blood transfusions. Eclampsia is always remains a common differential diagnosis. Though there was no witness seizure, she did not have any comorbidities like preeclampsia during delivery during the antenatal period. And hypothermia definitely is a striking diagnosis which will come to our mind because temperature was 106 degree. And I would just point to note that this patient's blood pressure was preserved with that kind of tachypnea and tachycardia and temperature. Blood pressure was preserved in a sepsis patient who will have this degree of fever and this kind of cardiac arrhythmias or temperature. Unlikely, very less likely that blood pressure remains preserved. But this is a point to note in these cases. She got intubated. She was resuscitated with fluids with crystalloids. Because of there was a suspicion of seizure because she was not very well monitored in that district level hospital. We did end up giving magnesium sulfate injections and lorazepam as well, and started on broad spectrum antibiotic after sending appropriate cultures, as Dr. Ray said. And ultrasound abdomen was done to rule out any retained product of conceptions, which was not there. And there was minimal soakage from the fresh wound of the surgery section. So she was shifted to ICU, and these are where the lab parameters. You can see a raised TNC count of around 14,000 almost there. Platelets are normal. Creatinine is marginally definitely high. She has got acute kidney injuries. Other electrolytes are preserved. And these are all deranged. The liver function test is deranged, are in hundreds, the enzymes. CPK, which we suspected and I sent, came out to be around 1400. So it's definitely high. Now, further history from the family and the attending doctors from the outside hospital. The obstetrician also rang to mention about the circumstances prevailing in that district level hospitals. This lady came to that district level hospital at 6 p.m. and there was no air conditioning functional in that unit from a night to morning, and thereby actually she was exposed to a lot of heat. She was also covered because she was undergoing the process of induced labor also overnight. So she was tremendously hot. And after delivery, the child had, of course, aspirated due to prolonged labor, and she developed probably hypothermia because she responded very quickly to the resuscitative measures, mostly the fluid resuscitations. Now, dramatically within 12 hours, the acidosis improved to normalize. Even you see the lactate has reduced, good urine output, and extubated next day morning at 10 a.m. This is one of the very few patients that we could extubate within 24 hours. And subsequently, she was shifted out. All cultures came negative, and antibiotics we could de-escalate by day 3. So keeping in this all these points in mind, I think the points which are in favor of diagnosis of hypothermia, where it is high temperature, prolonged labor, the history that the obstetrician gave, severe metabolic acidosis, raised CPK and other enzymes, deranged liver and kidney functions, and rapid response with resuscitative measures and hydrations. So in this context, I would like to ask Dr. Pratibha ma'am, what will be the definition of hypothermia? How do you define hypothermia?
So any temperature more than 104 degrees Fahrenheit, taken core temperature, not oral temperature, either rectal temperature or intranasal temperature, more than 104 or 40 degree of centigrade is considered as, by definition, as hypothermia.
Is there any concomitant requirement with that? Just the temperature recording or any other organ dysfunctions or anything? Is that necessity to define it, hypothermia?
Hypothermia per se, usually these people are having other, manifestation of dehydration, and hence prerenal azotemia could be there, CNS dysfunction could be there. But for saying hyperthermia, I don't think it's necessary to have the dysfunction, organ dysfunction.
So it is
Basically
usually
for heat
associated-
stroke, if you put it as heat stroke, then in the definition CNS.
Yes, in
function
heat
CNS
is
stroke,
definition,
different thing,
yes,
but
you're
for
right.
hyperthermia per se, you don't need.
It is only the temperature, right?
Yes.
So temperature along with the CNS dysfunction comes to qualify for the definition or diagnosis of heat stroke in the setting of a large environmental
severe heat
load,
stroke,
severe
stage 3
heat stroke, right?
would,
So it
would
is
have
potentially
organ dysfunction.
right. It's a potentially fatal condition that requires rapid identification. Mainly, you have to extract it mostly from the history. So how do you rule out sepsis from heat stroke or hypothermia, Dr. Jose, if you can answer that?
Yeah, thanks, Sharmali, for asking. Very important question indeed. As Sumit has already mentioned, in this situation, when you have a patient post-cesarean with high temperature and organ dysfunction, of course, you need to consider sepsis as the first diagnosis. Of course, the overall picture and the way it panned out strongly suggests heat stroke. But you should actively hunt for a source of sepsis. In this case, she had a cesarean, so intrauterine infection may be an important cause of puerperal sepsis. You will, of course, do well to do imaging with ultrasonography by the bedside, maybe even a CT scan. And of course, the blood counts. Blood counts, of course, may be high in heat stroke as well. So it might not confirm the diagnosis one way or the other. So sepsis is an important consideration, at least when you see the patient initially, and you will need to seek a source and actively address it if it is appropriate. And of course, empirical antibiotics you would consider anyway in this case, because there is no way you can rule out sepsis with any degree of certainty. So you would definitely do that, and at the same time, seek a possible source of sepsis. Of course, as I mentioned, as things turned out, it was very obviously a case of heat stroke because she got better within a matter of 24 hours, got extubated, and organ function started resolving as well. So given that information, of course, it looks very much like heat stroke, but do consider strongly the possibility of sepsis when you initially see this patient.
Right. Thanks for highlighting those important points, sir. And how do you define, how do we generally differentiate between fever and hypothermia? How are they different in terms of their pathophysiology or genesis?
As we discussed, hypothermia means just rise of temperature, and rise of temperature to more than 104 degrees. Some definitions say more than 105 degrees. 40.5 degrees centigrade is the temperature that is the cutoff set as hypothermia. So the basic mechanism in hypothermia is that there is increased heat production, which cannot be dissipated adequately by the normal compensatory mechanisms of the body, including the hypothalamus, sweating, and so on. So the temperature keeps building up. And this is, of course, regardless of the use of antipyretic medication and so on. So you do need active cooling techniques. Fever, of course, occurs with mostly due to cytokine release, and it usually doesn't rise to the extent that we mentioned of 104 or 105 degrees centigrade. We commonly see it in infections of all types, sepsis, SARS, etc. So the absolute level of temperature, as well as the fact that it doesn't respond to antipyretic medication in the usual manner, would all suggest that it is hypothermia that we are dealing with and not a run-of-the-mill case of fever.
Right. There have been some issues with the links. I have been forwarding the links. Thank you. So regarding the pathophysiology of hypothermia, Dr. Rai, Dr. Sumit, if you like to discuss how it is, what is the genesis and how it leads to multi-organ complication at one go.
Right. So probably we have to differentiate into broadly two patterns of heat stroke. One would be the exertional and the other would be the classical. Exertional more common in young people working outside or working out, exercising. In the Indian context, more than exercising, which you see in the West, athletes, etc., we have poorer people working as laborers in the heat who have no choice but to work even in the peak heat. So they are the ones who are more prone to exertional hyperthermia, while the elderly are more prone to classical hyperthermia. In the exertional hyperthermia, it is related to more heat production, and the production is so high that there is an inability beyond the point. There is no compensation of heat loss, which is adequate. Initial phase of sweating, etc., is not able to keep the heat out and take the heat out, and that is why that happens, broadly. While in the classical one, basically the heat loss mechanisms are kind of affected in the elderly and prepubertal, and sometimes the obese also, where the heat loss mechanisms are affected. So those are the reasons where which is, as Dr. Chacko said, between the balance between production and loss. And in the classical one, you probably will have the elderly who are not sweating, dry skin, etc., with the high temperature. And disorientation is an important part of heat stroke diagnosis. So these would be the elements that you're looking for. Sorry, just repeat the question. Anything else that you wanted to?
Yeah, that's broadly so. Between the exertional and non-exertional heat stroke, how do you and different? What are the mechanisms? As you rightly very clearly pointed out, these mechanisms are different, and these are simple mechanisms, and thereby actually the mode of treatment and the cooling also makes a difference in the approach and management. That is why it is important to know this. So my question will be to Dr. R.K. Singh. What all systems? It's obviously, as we have come to hear all the panelists by far now, that it's a multi-organ, event or affair. So what all systems get affected? How do they clinically manifest? Please unmute yourself, sir.
With hypothermia, since it's a multi-organ dysfunction syndrome component, so you will have, as the definition of heat stroke goes, you may have involvement of CNS. There can be involvement of hematological issues. So there's inflammation as well as there is thrombosis related spectrum in the hypothermia-induced heat stroke. So you will have CNS abnormalities, you can have cardiovascular, you can have respiratory related issues, then renal and liver related problems, and if the spectrum really worsens, then you can have a DIC phenomena. Once I say DIC, then almost everything gets involved. So it is a multi-spectrum illness. If not managed in the right time and in the right manner, then you will have all the spectrum coming to you.
Probably, if I may add,
yes, please.
Is that I think, it's kind of been divided into probably three phases, where you have the initial phase of, the neurological hyperthermia with neurological symptoms. Then you have the enzymatic and the, hematological dysfunction of DIC that you see, and that, microthrombosis also. And the third phase is the renal hepatic phase, which causes the renal failure and the hepatic failure. And another important thing is, and the process of triggering all this is related to the same SIRS with the triggering of the interleukin-1 and the 6, which triggers all the rise of the cytokines, leading to the same kind of phenomena that you see in sepsis. SIRS, I would say rather, which is also so. So that's
the gut translocation
absolutely
is also there.
Absolutely,
so they're all connected, it seems.
Yes.
Right. So as Dr. Sumit and Dr. Singh very pertinently pointed out, that it is the mechanisms are very similar to SIRS response. There is a cytokine-mediated systemic inflammatory response, and in addition to that, there is also production of something called heat shock protein. Yeah. It also starts rising, and almost all epithelial and endothelial cells of the body get affected. That's how it's become a multi-organ dysfunctions. It might lead into failure, multi-organ system failure in severe cases, and DIC. So what are the factors associated with the increased risk? Dr. Pratibha, if you can tell us risk factors where they develop severe manifestations of heat stroke.
The most important risk factor in classical heat stroke is age, because many of these patients are on multiple drugs. They are sometimes on antipsychotics also. They don't consume too much of fluids. They are on diuretics many times. They have other associated conditions also. And they have, poor sympathetic, parasympathetic activities to help in heat dissipation. So the most important risk factor is age, elderly, and the children who are pre-pubertal, younger children, maybe below 11, 12-year-old children. They are also at risk because of their body surface area and poor mechanisms to dissipate heat. So that's one age group. Another one, people, those who are working out in the heat, or just like as my previous speaker has already mentioned about laborers, those who are working in hot conditions, or athletes, or especially these marathon runners and all. They are also at a very high risk of developing exertional hypothermia. So that's one major risk factor. So environmental factors and of course coexisting drugs.
Right.
These are major reasons where you can have plus many times, if you're less acclimatized to the heat, say you've come from abroad and here you used to 28, 29 degrees centigrade, and now you have to face, in like in Ahmedabad, we have about 48 degrees centigrade also. Some areas of Gujarat have recorded 48 degree temperature. So that high temperature is, or traveling in non-air conditioned vehicle, or in the hospital. Sometimes even heat stroke can happen at home also. So these are situations where these people are at a high risk of developing.
And along with these patients who have this comorbid conditions, the diseases like more common ones
Yes.
found like the diabetes, cardiovascular diseases, because they'll be on different drugs like beta blockers or or different drugs which can modulate their autonomic
Mainly
responses.
elderlies are they are on some or other drugs, like
and those who are
diuretics
addicted
or
to alcohol,
antidiabetics.
they are the ones actually more prone. So
Absolutely.
types of heat stroke, Dr. Sumit Ray has already narrated this. And coming to the neurological features, Dr. Jose, if you can narrate on what are the kind of spectrum of neurological manifestations that can happen in a patient who suffers from heat stroke.
Yes, I distinctly remember when I used to work in Australia a long time ago, they used to come after drug-induced hypopyrexia, and in the hot weather, they sometimes continue to exert physically for a very long time, dancing, drug abuse, and some of them used to come after a very vigorous exercise session with during military training and so on. So in that situation, when they come to you, many of them would be agitated, restless, and you may not really understand as to what's going on in this situation. So, and of course, the temperature would be very high, and that would be a clue to the fact that it may be heat stroke. And in this situation, the other symptoms, other neurological symptoms, as you mentioned, would include disorientation. Seizures is a common presentation. Seizures, altered sensorium. Some of them come in deep coma, which is again a very important reason to consider other differential diagnoses as well, which we will discuss later on. Cerebellar ataxia is also a common manifestation, common neurological manifestation as well. So you need to consider pertinent neurological causes as well as a likely precipitant of this clinical situation, including meningitis, encephalitis, seizures due to other causes, and many of them may require imaging with CT or MRI scan, and they may need intubation, if not immediately, maybe at a later stage. And of course, they would need control of the agitation with benzodiazepines, propofol, and so on once they're intubated. So it's neurological manifestations are very common, and of course, the care is mostly supportive plus active cooling, as we will discuss later.
Right.
Just to
knowing the Australians.
Certainly,
just to add to the everybody thought, We have to understand that heat stroke is the basic pathophysiology resetting of the thermostat center. And suddenly your temperature goes, but body is not able to adopt the temperature. So one group of patients which is very commonly missed, which I have seen, the elderly patient where their baseline temperature may be much lower, maybe 96 or 95 degree. And for them, when suddenly temperature goes up and they, even it is a 98-degree temperature, this 4-degree increase without sudden increase, particularly when this weather comes and particularly when they are taking antipsychotic, antidepressant, diuretics and cardiovascular drug. These are the patients very typically presents with two features. One, they suddenly become very irritable. Their temperature remains 98. For you, it is normal, but for them, it is almost 4-degree temperature without getting a time to acclimatize with the heat, which comes very new. And the third thing, that suddenly there will be jump in the baseline creatinine of around urea 2 times, maybe more, and then they even passes less urine. So this group of patients, particularly when they come, particularly when heat comes and elderly comes to you without any explanation of irritability, keep even the temperature is normal, keep a very low threshold of diagnosis them a heat stroke patient and hydrate them well. And at least in this season, I have seen around 10% of this category who has come just with elderly and this kind of features. Just to add to that.
Was
Right.
there an associated hyponatremia or something, dyselectrolytemia, Dr. Mishra?
Yeah. Sodium was low and potassium was high.
So that's why they trigger, even with not such a high temperature, they trigger
Yeah.
neurological symptoms earlier.
Yeah. And CPK was invariably high, but not that much, but high. And the creatine jumped up, urine dropped, potassium was high, and sodium was low. That's what the feature. Yeah.
Right.
So just this group of patients is very commonly missed, and one has to keep. They can go for the people can go for the battery of investigation of MRI, CT, and whatnot. But simple hydration and just in few hours, these patients are back to the normal.
Right. And that could be also along with this very, very common, manifestations and presentations. That could be extreme cases like, presentations mimicking Guillain-Barré syndromes and Parkinsonism has also been reported due to the variety of changes. Again, coming to the non-neurological changes, would you like to highlight, Dr. Sumitra, about the non-neurological manifestations of a patient?
Sarmili, you should ask some question to Ashish also. Ashish Valla is there.
I can't see him, sorry.
I don't know.
No, you can't see me, but I can see you and hear you.
Okay,
So
okay, great.
Ashish, I think she has forgotten you that you are also a panelist.
No, because she had not joined actually. Sir had not joined.
So I was finding it difficult to join, but I'm here right
I was
now.
told that you were not able to join. That's why I did not.
Yeah.
Welcome, sir. Welcome. Great
Now
to
you can
have
take over.
But yes, as Dr. Rajesh has said, the neurological manifestations can be devastating, but then there can be other manifestations also. We have seen a couple of patients, especially the army jawans and the ones and the patients who who are not acclimatized to hot weather, and they go on a run or a jog or do an exertional exercise. They can have significant renal failure, they can have significant rhabdomyolysis, they can have liver injuries. So these can be non-neurological, but they can have neurological manifestations. And out of them, I believe DIC, I would say rhabdomyolysis, if it is exertional, and kidney injury, hepatic injury are major important events. And by the time a patient presents with seizures, it's probably too late in the day.
Right. So coming to the respiratory dysfunctions, what could be the spectrum of respiratory dysfunctions, Dr. Sumit, in your experience?
Yeah, so respiratory dysfunction could be basically related to the severe acidosis relating to causing hyperventilation, tachypnea, and respiratory alkalosis with a severe metabolic acidosis, and huge amounts of of worsening acidosis, because the exertion required to blow out the CO2 to maintain the pH in a young person can lead to further metabolic acidosis and lactating, because of respiratory requirements. So that would be one subset which would require intubation. ARDS Not to tell you honestly, I haven't seen that many ARDS related to whole heat stroke in the recent past, but also that is related probably to, public hospitals get more exertional heat stroke patients than private hospitals, where you would see this probably much more the severity of illness that you get. Obviously, less socioeconomically, lower socioeconomic strata patients tend to go to government hospitals, where they are, those are the ones who are more prone to exertional heat stroke. And ARDS, secondary infections, and any form of thrombosis is a possibility in the setting of, it could be pulmonary, it could be cerebral, because there is, hemoconcentration because of the dehydration to a certain extent. There's a prothrombotic state with microthrombosis possibility, which could be a coagulation abnormality with a restate coagulation. So pulmonary infarction could also be a possibility. But the predominant one is a high metabolic demand, which is not met by the patient's own ability to generate. So that is where we need usually intubation and a loss of consciousness or a GCS low, where we would need to intubate the patient.
Yeah, exactly. As you rightly pointed out, these patients generate, the work of breathing is generally so high when they're present initially. We have to take over the work of breathing and then need rest along with resuscitation with fluids. And it is seen that in of the small case series, though, up to 86% of these patients in one of the studies in a review showed that they developed respiratory failure. It may not be necessarily ARDS, but they did develop respiratory failure requiring mechanical ventilation. But the outcome is also good if if it is not too late. And coming to the cardiac dysfunctions, Dr. Ashish, if you can tell us about what could be the spectrum of cardiac manifestation in these patients, because we have a very susceptible population of elderly patients who are on multiple drugs as such. So what could be the spectrum of cardiac manifestations in these patients? Dr. Ashish.
The cardiac dysfunction can vary, in these patients. When you have a muscular injury of any kind and when you have DIC of any kind or thrombotic manifestations of any kind, any tissue which is a high demand, high metabolic demand would get affected, and heart would definitely get affected in these. And the couple of reasons for that could be, one is the raised temperature, second is the dehydration. The heart tries to meet up, and if you couple it with the tendency to hypercoagulate and to have a microvascular dysfunction, you may have a myocardial injury, may precipitate decompensated heart failure, and that might manifest in the ECG or in the monitor as maybe arrhythmias, sinus tachycardia. Sinus tachycardia as such would be more common if you have dehydration associated with whatever the heat stress is there. And then you may even have a stress-related cardiomyopathy kind of a picture. That is what is the most common thing which would be seen. And I would say that if you have any kind of decompensated, until unless you have a frank heart failure, elderly patients, you may try giving them some hydration. But if you are suspecting heart failure, you have to be very, very careful in giving them fluid. So there, a point of care ultrasound may help you in looking at what is the status of the IVC and what is the status of the cardiac pump. And then you can decide whether you want to hydrate or you want to go a little conservative on that.
Right.
Dyselectrolytemias probably also.
But particularly, family, cardiac dysfunction, one of the commonest manifestations can be supraventricular arrhythmia, particularly the AF. In those patients where QT is prolonged, and again I will come because I distinctly remember two young patients who were taking antidepressant, little obese, and in heat weather they just came with the temperature. Temperature was not that high, 102-degree temperature, but the main limitation was their heart rate was varying between 150 and 160, and even LV function when we saw it was okay. and it took little bit of time for us to realize that it is a heat stroke, and we started hydrating the patient. And then within, in fact, as usual, a knee-jerk response, the moment you say AF, you give antiarrhythmic, but it not work. But after hydration only, their arrhythmias can be reverted. So one important point about the supraventricular arrhythmia in heat stroke, if there is no pre-existing disease, particularly QT is prolonged, and particularly if patient is taking antidepressant, antipsychotic, just simple hydration and waiting may work better than trying any other medicine.
Right. So as you rightly pointed out, this because you have to treat the cause, and antiarrhythmics actually may not necessarily work in these patients. And electric cardioversion, something which should be avoided until cooling is achieved, unless it is a life-threatening VA for pulse-led VT leading to cardiac arrest in these cases. And very important
more
point
thing I would like to point here.
Yes.
Sometimes giving overzealous vasoconstrictors can be a problem, because that would impair the heat dissipation. So if the patient is hypotensive, first try to manage them with fluids.
Right now we'll come to that. So if you have a high suspicion of heart failure in these patients, as Dr. Rashesh rightly pointed out, also you have to
and one more thing, Sharmili, we have to remember that if core temperature is high, better to give cold saline rather than just simple normal saline. That will bring down your temperature quickly. And most of the time, people try to give antipyretic in these patients. That also doesn't work.
Does not
should
work.
be avoided, actually,
because it is a central resetting of the thalamic hypothalamic point, as Dr. Mishra has pointed out. And renal, we have already discussed it. It is due to the phenomenon of rhabdomyolysis.
That is not proven, though, I think, Dr. Sharmili.
Okay.
About the resetting of the anterior hypothalamus, it's not yet proven. It's a kind of hypothesized, but it has not been proven yet, the resetting of the thermostat. It is a balance.
Yeah, Sumit, that is right. But the thing is that the message should go that in case a person comes with heat stroke, even if he has a high temperature,
that's
do not
true.
give antipyretics.
Absolutely.
No, not give antipyretics. That's important.
That I don't disagree at all. But I'm just saying that the resetting of the thermostat is a bit in question even now. Yeah. So, and the other is the reasons for arrhythmias would be significant dyselectrolytemias. Initially, there could be hypophosphatemia, hypokalemia, later hyper of both these things, hyperphosphatemia, hyperkalemia.
Yeah, so as you rightly emphasizing on this electrolyte point, it is very, very important in these setups. And very few of them might actually end up with kidney replacement therapies if they are not improving in a certain span of time. Coming to the GI effects, again, all, as we mentioned, that all the epithelium, endothelium, all cells get affected. They do manifest some forms of deranged liver functions with raised liver enzymes. DIC can manifest as extreme cases, and literally any cavities or space of the body can have bleeding. Also, there could be small petechial rashes, just cutaneous rashes. Even the most extreme being intracerebral hemorrhage also in these cases.
Sharmili,
coming to the diagnostic evaluation, yes.
Yeah, the most important GI side effect is the feeling of nausea and not being able to take anything orally. That can at times be that can at times hamper the hydration in these patients. That's something which is very important, and that's seen. That is probably the first manifestation of heat exhaustion, which may progress on to heat stroke. So that is something which needs to be remembered again.
Correct. That's very, very important clinical point raised by Dr. Ashish on this point. And very often we see this actually in young child. These last 1 month, I have got complaints from many parents when their children sending their children to the schools, even it is morning school these days. They complain of these symptoms and they just go home and they vomit and they remain sick for 2 days. So this could be the initial trigger or the signaling sign for impending hypothermia if not attended early. So coming to diagnostic evaluation, how do you go for evaluation in these cases, Dr. Pratibha?
So besides the regular,
how do you go for diagnostic evaluation in these cases?
Besides the regular tests, especially the CBC usually shows the hemo concentration. There could be counts, total counts may be high. Blood gas analysis is very important. The blood gas usually shows if severe heat stroke is there, shows metabolic acidosis in these patients with high lactate levels. Then renal impairment, high CPK levels, liver enzymes could be elevated. Usually it is anictoric liver enzymes which are elevated. The bilirubin remains usually normal. And in severe situations, you can have DIC-like picture, or maybe just thrombocytopenia. So these are usually indicative of poor prognostic signs and severe heat stroke situation.
Right.
They
Dr.
should.
Sumit, would you like to add anything?
Among this, yeah, myoglobinuria, actually urine, sending the urine. I think Dr. Pratibha spoke about that. And temperature monitoring, and also while we are monitoring, investigating these, the frequency of, the frequency at which we should do initially probably should be twice a day. Some of the markers of, myoglobin, some in CPK, etc., the trends, the electrolytes and the creatinine, etc. So because the initial resuscitation and aggressive resuscitation is important, the trends of these, probably the first 24 to 48 hours, we may have to do it more frequently than usual. So that's also important, not just what we do, but how frequently we do it.
Yeah, there is a question in the chat box about any role of fibrinogen check and cryoprecipitate as a routine standard management in these patients. Would you go for a fibrinogen check in these patients initially if there is a severe heat stroke, you believe?
So if there is DIC and bleeding, yeah.
Otherwise not. Yeah, it is not necessarily for all patients. So it was a question in the chat.
Certainly, the DIC, particularly when this patient goes in very severe cases, because it leads to activation of endothelial dysfunction, endothelial paralysis. These patients very quickly go into the DIC, initially thrombotic and later on bleeding if it is left over. So if you want to pick DIC in this patient early, there is a role to monitor fibrinogen level, and that means if patient has come to very late, particularly patient is developing a lot of severe renal dysfunction, severe metabolic acidosis, not responding to quick hydration, there is a role, because DIC is one condition which kills this patient.
True. In severe cases, if they have an infrastructure which allows you to monitor fibrinogen level, you can at least get done a baseline and monitor these patients clinically. You can subsequently follow the trend and do the needful for these patients. Coming to we have already discussed about this necessary investigations. However, there will be many situations we'll have to rule out other, significant medical conditions which can closely mimic the heat stroke or hypothermia. So toxicology screening is a very important one of these, as Dr. Juice pointed out, Dr. Pratibha and Dr. Sumitra pointed out, because many of the drugs are there. Patient may be taking illicit drugs during parties, etc. Those have to be looked for in these cases, and the list is really long. And CT head in brain would actually also necessary in few of these cases. If you have unequal peoples, if you have any suggestive history which could actually be precipitated this hypothermia, because we know all that blood in CSF can cause also hypothermia. So some of these cases we actually have to do CT scan at the beginning also before you start treating these patients. So what are the close mimics?
Can I come in? Can you stay on this slide? There are two things which are very, very important. Or three things: ethanol, cocaine, and lithium. These are three very, very important things. Cocaine, although very low potential of abuse because of the high cost, but then it is available, and it is available in the metros. So should be, especially during the hot weather, should be careful. Ethanol can also cause issues by causing dehydration more, and especially with lithium. If you are not taking adequately orally, elderly who are on lithium may go on to develop renal failure, may have high level of lithium and can worsen renal failure. So they may go into lithium toxicity kind of a picture. So these are important things. These people need to be carefully monitored. The excessive alcohol intake, the potential cocaine users, and the patients who are on lithium.
All right. So one has to be careful. The history remains of paramount importance in these cases, circumstances plus the drug and the comorbid history of comorbidities in these cases. So the close mimics, would you like to enumerate, Dr. Sumit, about the close mimics of heat stroke and hypothermia for those who have joined us late? Yeah.
Right. I think it has been mentioned, but meningitis would be one. Malignant hypothermia would be another, encephalitis, etc. Any stroke, an SH can cause significant high temperature with unconsciousness or neurological symptoms. And left malignant syndrome also could be a possibility. Those would be the ones, I think, those mimics. Dr. Ashish would probably add to it.
Right. Dr. Ashish, if you can say how to differentiate between, suppose I would say one of my juniors would say it is, why not it is malignant hypothermia versus heat stroke. How do you like to, how can one differentiate between these two entities? Malignant hypothermia and heat stroke. And Dr. Ashish or anyone?
Yes, I'm here. Malignant hypothermia and neuroleptic malignant syndrome, especially in patients elderly or the patients who are on antipsychotics, they are more prone to develop it. And you would find that there will be definitely rigidity, muscle rigidity, which would be very common in them. And the rest of the symptoms may mimic those of malignant hypothermia. They may have neurological manifestations also akin to this. The temperature can go significantly higher. So sometimes it may be very difficult, but specifically look for muscle rigidity.
Right. And
history of anesthetic agent is the most crucial part in malignant hypothermia. Usually scoline. These patients are...
most of the time, these patients, those who want to develop neuroleptic malignant syndrome,
no, I'm talking about malignant hypothermia.
Okay, malignant hypothermia is okay, fine.
Yeah,
that
malignant hypothermia.
Halothane also. Yeah.
Halothane. Well, these are the common,
it is like that. The moment you give halothane or this succinylcholine, and your anesthesia water start bubbling like crazy, and you know that something wrong has been done.
And the head starts bubbling also, the anesthetist head also. So it's very, I mean, one has to
history of SSRI is very important for NMS. Many of these
yes. So it's an NMS, that's neuroleptic malignant syndrome, is an idiosyncratic reaction, especially associated with this first and second generation antipsychotics. Of course,
and one more thing I would like to add, many times linezolid is used in ICU for some suspected gram-positive infections. And if the patient is on SSRIs, there can be severe malignant hypothermia. I mean, not malignant hypothermia, neuroleptic malignant syndrome kind of a situation can occur.
So like what could be, I mean, these are the complications that we've already discussed in these cases. So how do you go about managing these patients in ICU? Dr. Jose Checo.
Yes, thanks, Sharmali. Very important question as to how do you handle a patient who's come with severe hypothermia. The primary focus, once you are fairly sure that it is indeed malignant hypothermia and the temperature is high, more than 104 degrees Fahrenheit, the focus should be on bringing down the temperature. And there are two main methods by which you can achieve a drop in temperature. First is very easy to do, surface cooling. And by surface cooling, you need to expose the patient completely, devoid of all bed sheet, clothing, etc. And the easiest thing to do is to splash him with water. Although people normally use cold water, it may be appropriate to use lukewarm water to do this, because it may have a more effective, more efficient cooling effect than absolutely cold water. But water at any temperature, even cold water would do. And with the help of fans, the idea is to let the water evaporate, and evaporation leads to surface cooling. So that is the first easy step to do by the bedside. The second step would be to infuse fluids. You need to infuse fluids anyway, because these patients are very vasodilated and they will take a lot of volume, especially the younger patients. So you need to hydrate them. And when you give them intravenous fluids, you should use cold solutions at a temperature about 4 to 5 degrees centigrade. So very important to keep some cold IV fluids in your ICU fridge, because they can come in handy in a situation like this. And how much do you cool them down? The general recommendation is to cool them down to about 100.4 degrees centigrade and 100.4 degrees Fahrenheit or so. But there is some good evidence to suggest that you can probably keep on cooling to near normal levels, so close to 36 degrees centigrade. So you can continue with this process of cooling. Of course, you don't need to make them any colder than normal. Now, that is the first and the most important step in terms of management. Then, of course, there are other techniques like immersion in ice cold water, which very few centers have the facility to do, not very practicable. And then supportive care, very important, depends on the level of sensorium. Many patients may require intubation ventilation, particularly if they're agitated. And cooling is not easy in awake patients. If you're doing active cooling, it'll cause shivering and very uncomfortable. So at least temporary intubation and mechanical ventilation would be required in many of these patients. And then, of course, you can use benzodiazepines. Propofol infusions are good. These would calm down patients who are restless, and neuromuscular blockade may also be required. So these are the main supportive measures.
Thank you, sir.
Can I just
please.
Just a couple of things. One is when we use propofol, so our worry in this rhabdomyolysis, we have to be a little more careful when there's a persistent, if there is rhabdomyolysis with the propofol, the metabolic acidosis can worsen. The second, sir, I'm a little doubtful about the use of lukewarm water, because I think if you, all evidence shows that immersion in absolutely ice cold water is the best way to cool people. If we can't do that, putting cold water should not cause any problems. I
agree. In practice, we do that, but the theory behind it is that, at least the theory, is that cold water doesn't evaporate quick enough. So if you use it slightly warm in the sense, it'll be lower than body temperature, of course. So if you use slightly warm, it'll evaporate better and increase the efficiency of cooling. There's a theory behind it.
Right, sir. I think the other way to do it probably, and correct me if I'm wrong, is that you use a cold water and the air that you blow can be a little warmer. So that's the other way to do it. Actually, that causes more evaporation, supposedly. What you are saying, in principle, similar, but flip it. Like the water should be cold on the body, while the air that is coming is slightly warmer than usual. So that's probably,
immersion is okay. Immersion is direct contact with it by conduction.
Yes.
But if it's by evaporation, it might be more effective, at least in theory, if you use slightly warmer.
Dr. Jose, you are absolutely correct. Evaporation is much better than immersion. Although immersion is recommended, but evaporation is what is more practical and can even be done at a peripheral center, where you can just spray water over the patient's body and put a fan. That can work perfectly well.
That's a simple first step.
One point I would like to add is about, to Dr. Sumit, that about putting cold water, the only disadvantage is this patient starts, moment they starts shivering, actually heat generation also increases. And in a bid to suppress that, actually one, many centers end up using the benzodiazepines to suppress shivering. And my next question would be in that continuation about when these patients continue to throw continued seizures, what will be your agents of choice for controlling the seizures in these cases? Dr. Sumit or Dr. Ashish, anyone, please. Or Dr. R.K. Singh, I cannot see that.
I think
benzodiazepines
are your preferred choice, because you don't want shivering to happen and you want them sedated. Anyway, you are protecting the airway. So my choice would be benzodiazepines as a preventive measure.
Right. And it is advised that not to use barbiturates. I mean, I think this is a very important point, and the message should. Is there any particular reason for that?
Probably it causes hypotension, severe hypotension.
More of vasodilatation and hypotension compared to
even penicillin is not recommended.
The neurological aspects may be more difficult to monitor, you may not be able to understand the neurological sequelae to a barbiturate dosing in a patient with an altered sensorium, with benzodiazepines and seizure background. So it may be more confounding as an agent if you use it in this scenario.
Also, microcirculatory dilatation is more with barbiturates. I don't know how that would affect it, but I'm just thinking through this. I know it has been written, but microcirculatory vasodilatation I mean, dilatation is more with barbiturates as compared to benzodiazepines. So could
Yes,
that
it is.
affect it? I don't know really, actually, to tell you.
Yeah,
honestly.
it is more of the profound vasodilatations, so which might precipitate for the hypotensions and this microcirculatory dilatations as well. And if you're giving us an infusions, the profound effect, CNS depressant effects persist compared to the this benzodiazepines which have a shorter duration of actions. So in that go along with, as Dr. Chose has actually ranted, the overall supportive care and resuscitation for these patients. How would you address the hypotension in these cases? Would you, like in patients, sepsis patients, after a certain degree of fluids use and vasopressures? So what will be your approach to manage hypotension in these cases, Dr. Pratibha?
So the mainstay of correcting hypotension is fluids only. And if the fluids don't work, then vasopressors can be used. But there is a lot of controversy on choice of vasopressors. Basically, noradrenaline is supposed to be causing more vasoconstriction. So it would impair the heat dissipation. So it is advised that when using noradrenaline, one can use probably adrenaline and dobutamine. Problem with dobutamine is
right. Yeah.
Problem with dobutamine is that it is more arrhythmogenic. So one should be prepared for arrhythmias also in such a situation.
Dr.
So,
Sumit, do you agree or you do? Yeah.
As far as possible, I would probably avoid using any vasopressors. I would
yes, of course,
I would probably give IV fluids and maybe give optimize IV fluid based on the POCUS findings. I would probably look at the heart and the IVC and try to do that. If at all I want to give anything for the heart, failing heart, it will be inotropic agents rather than the vasopressors.
Do you agree, Dr. Sumit? Dr.
I mean, the principles I agree with, but possibility of using, I'm just asking the question, probably adrenaline would have less alpha agonist action rather than noradrenaline being the first drug of choice in a vasopressor. So using adrenaline, which was, possibly that would be a better drug to start off with. The fluid resuscitation, without doubt, of course.
Yes, true. But I would differ on that. I mean, Dr. Jose,
the question of, fluid resuscitation, definitely only when the patient does not.
But if there is persistent hypotension, that had to be, NAP has to be, it has to be, perfusion has to be made optimized. So in that direction, then would you, if we have to end up using vasopressors, because we cannot let hypotension to persist for hours together. So to optimize microcirculations, we have to.
You will have to use a vasopressor if the situation demands.
If need arises after all these adequate measures, and you have assessed fluid status, if we come to that phase, noradrenaline still remains the first choice. Yes. Alpha adrenergic agonists have to be avoided, like the ones we use in OTs like this ephedrine or phenylephrine. That has to be avoided because these are the ones which are more potent vasoconstrictors, and they'll prevent dissipation of heat. So alpha adrenergic agonists have to be avoided. But if you are in a situation that we have to end up using one of the vasopressors, noradrenaline does remain the agent of choice. And regarding uses of dobutamine, if you have corrected all your electrolytes, the cardiac dysfunction demands or mandates use of any inotropic agent, dobutamine is the agent of choice. We have discussed all these things.
There is data of milrinone also being used. Milrinone, yes.
Right.
In such a situation.
Yeah, there is a question actually regarding cooling method. I think we had already discussion on this. I would like to hear from the panelists about possibility of using or the role of extracorporeal circulations in managing hypothermia. Dr. Jose.
I think this situation, I would consider it as a potentially quickly reversible condition if you handle it with conventional measures. And I doubt if there is any kind of experience with the use of ECMO in this situation. If it is to cool them down, you can very effectively cool them down by surface cooling or using cold IV fluids or immersion if it's absolutely necessary. So I do not really think that such extreme measures as the use of ECMO would be mandated in this particular situation.
Sharmili, I think this is a very good option, but the only thing is, although we say we need to rapidly cool, how rapidly no one has studied. Since there is no definitive although it stands to reason that you need to rapidly lower the temperature, and extracorporeal, support devices can do that pretty rapidly and would help. But has anyone used it and looked at what are the long-term effects of that rapid cooling? I'm not sure.
So
there is a review in NEJM.
Yes.
I'm sorry.
Yeah, sorry. So go ahead. Yeah.
Yeah, please.
2020, there is a review in NEJM about cooling, and there they have mentioned about ECMO, and they have mentioned about intravascular cooling devices, which are placed in IVC and can bring down the temperature as rapidly as within 20 to 30 minutes, also as rapidly as 0.1 degrees centigrade per minute.
Yeah.
So, and there has been a vis-a-vis study also whether conventional methods versus this is supposed to have better results, but I don't know whether in our country we can ever think of such things, because heat stroke usually affects a very
yeah, you are right, Sharmili.
Can I suggest
the ones
something?
Who are more affected may not be able to afford ECMO, and the ones who can afford ECMO may not actually develop heat stroke.
Can we
state makes it free.
Can we use a dialysis machine?
Yes, that's my next question. That's what my next question.
We can do that. Probably that would be useful because you can bring down the temperature on the dialysis machine depending on the machine.
Peritoneal dialysis with cold fluids can also be done.
Yeah, even hemodialysis.
Yeah,
hemodialysis. Intravesical ice water can be given, which is a much simpler and cheaper method. Ice water.
In terms of rate of lowering temperature, this invasive means might have a role, as Dr. Sumit pointed out.
Can I come in?
Yes, sir, please.
Yes, somebody mentioned gastric lavage with cold water. I don't think there is enough surface area available with the cold water or hot water peritoneal fluid lavage. There is a large surface area which is available, which can be cooled or the temperature may be raised. With gastric lavage, there is a very small surface area and may not actually really work.
These are actually contributory methods. The main method remains surface cooling only.
Yes, right. But I think still there is a potential in our country to use a dialysis if the patient has AKI with. If you are using the dialysis machine or you are finding it difficult to cool, I think the dialysis machine could be an useful adjunct for bringing down temperature. I think it is an absolute possibility that you can use.
I agree
that is something which is possible and can be done and should be
done.
Right.
Absolutely.
If the patient has one of our, then this is a good option.
I've done that actually. I've done that once. Yeah.
Right. Did it really result?
Yes. It brings down. Absolutely. Okay. It brings down the temperature.
And one of our colleagues who regularly does ECMO from Eastern India, he mentions about a case report from Japan where they have used VA ECMO for severe heat stroke in a patient with refractory hemodynamic failure. That's a case report from Japan. So I think there is a good potential. I mean, in refractory and very, very unusual cases, of course, can't be
probably that's a bit of a hammer for killing a fly. Which is used,
but in refractory, some of the cases, and as you have tried, you have minimized it. Anyway, you have used it in the form of dialysis.
Dialysis is less invasive in terms of the ECMO. Relative to VA ECMO, it's a much less within quotes invasive methodology. So
I think they are probably mentioning a patient who had severe hemodynamic instability who requires circulatory support.
Yes, with a VA.
One of cases.
Then it's a different.
Can't be a routine one.
Yes. True.
So we have already discussed about the temperature targets. Dr. Jose has mentioned that the factors which are associated with worst outcomes and increased mortality remain these. Again, organ failures, the worst ones being the anuric, acute kidney injuries, anuric, patients who are in profound coma if there is hemodynamic instability. And DIC is always a very, very poor prognostic factor in these cases. And you see some of these case series indicate a high mortality rate up to the 20 or up to the tune of around 63% in these cases. Long-term outcomes, what could be the, what are the, in your practice, if you have seen, what are the long-term outcomes for these patients? Because it's an acute insult, but nevertheless, it leaves a print on the body, and down the line after years also, patient might have reminiscent organ damages that can manifest or lead to chronic diseases. So Dr. Sumit and Dr. Jose or Dr. Mishra, anybody would like to comment on that?
I mean, I won't comment only on like one event of hyperthermia and heat stroke, but there is evidence now to suggest that people who work in very hot conditions, iron workers, workers of sugarcane plantations, etc., chronic repeated bouts of heat exhaustion and heat stroke actually ends up causing CKD, chronic kidney disease, which was earlier called CKD-U, CKD unknown. Is now being diagnosed in very hot countries. The initial diagnoses came from Sri Lanka and Brazil. So repeated bouts of high functioning in high heat for laborers who don't have access to good quality cooling afterwards or hydration, they can be exposed. The other ones, for the immediate one, cerebral ataxia may be persistent, autonomic dysfunction may be persistent for weeks. But this is an interesting one which really came as a story in Science journal, which was very interesting, which I found, the CKD.
Right, so we are coming to the end of the session. So we'd like to summarize the session. Anybody would like to put any inputs on before we summarize? You can take a few of the questions which are in the chat box. There's a question on uses of NSAIDs to lower temperature in these cases. It is understood that higher temperature, when it is in the range of say 104 and 105 degrees Fahrenheit, we are not advocating to use NSAIDs because the hypothalamus will most likely won't be functional at this point. But once it comes down to say 100 and 101 degree Fahrenheit or below that, would you be considering using NSAIDs in these patients during stay of ICU? Anyone?
Not particularly. In the initial stage, the focus should be on active cooling, and NSAIDs may not be particularly effective ones. Second, they may actually be harmful in this situation, particularly if they are on the verge of renal impairment. So I wouldn't use them in that acute stage. Certainly the focus would be on effective surface as well as cooling by IV fluids mainly.
Right. Thank you very much, all the panelists. And I think we have come to the end of the discussion, panel discussion here. So as we have come to understand the history of the circumstantial exposure and clinical examinations, which is very, very important. Comorbid conditions we need to know in detail, and along with the disease and drugs, because of the extreme of age that we have, our panelists have pointed out, they are likely to be on higher amount of higher number of drugs, and high grade of suspicion has to be there for atypical presentations, because by the time the patient come to the medical center, they might have received some cooling measures, and actually the temperature may not record so high, and we need to have particularly the esophageal or rectal temperature measurement to diagnose this, the numbers that you're talking about, 104 or 105 degrees. So if you're just using a surface thermometer axillary or the oral one, they may not record the actual core temperature. Rapid cooling remains the key supportive measure since ICU as soon as possible without delay remains a very key determinant of the outcomes. Organ dysfunctions can ensue in both in the short term and in the long term. And we have heard Dr. Sumit saying about the possibilities of chronic kidney diseases or even some neurological dysfunctions might persist in the long term. Many have actually, there are some case reports and small case series about persistent retinal damages, cardiac irritabilities or arrhythmias, or even GI dysfunctions also. And always, as is prevention is better than cure, it is always best to go for that. Thank you very much. I see, I think there are some comments.
Can you stop sharing your slides?
Yes, I will right now. Yeah.
Dr. Joseph, just in 30 seconds, if you can give a clear message for as prevention is better than cure. So what public should take as a message about heat stroke, what everybody should practice. We're not about extreme cases.
Very relevant point. We had first-hand experience at Ahmedabad, I must say. It was actually one of the most hot and a very kind of uncomfortable experience for me. And I have seen a little bit of heat in my time, but it was very, very warm indeed and uncomfortable in Ahmedabad. So the key is, of course, to confine yourself as much as possible to indoors. And if you have adequate fan, cooling, air conditioning or air coolers, that is always welcome. You shouldn't clothe yourself with too many layers of clothing. Of course, nobody would do in the heat, but try to wear as loose clothing as possible to allow the body to be cool, to remain cool, not to get heated up. And plenty of fluids to hydrate yourself, keep yourself hydrated. And as we heard, it is possible, especially people who work outdoors, who are confined to working outdoors to make a living, they might actually be exposed to the heat without even knowing that they are experiencing problems with hydration, renal dysfunction, and so on. So you should have water readily available to keep yourself hydrated. So these are some of the very important measures that are very important in situations where the temperature rises to close to 40 degrees centigrade or more. Thankfully, in Bangalore at the moment, as we speak, the temperature is about 20 degrees centigrade. So we are nice and comfortable here. I sincerely wish the situation would change up north as well.
Dr. Sumit, anything you want to add?
Yeah, thank Dr. Jose Chaco has the advantage of coming from God's own country and living in the neighboring state. So we all don't have that advantage, unfortunately. So, but as I not much to add to Dr. Chaco's what he has said. Unfortunately, I think among the things which has to be done is also a lot of, if it's a message to the public, it is also a message to socioeconomic factors are so important, because in the Indian context, socioeconomic factors are probably the most important factor of heat stroke, even more than the but mainly it's exertional, and so exposure to heat is changing the timings of work timings in peak summer, which many states have actually done. So during the peak heat, the workers in the construction sites, etc., should not be working outside. This is very, very important. The other thing probably which we miss out on in the Indian context, in the early phase of heat exhaustion, the sodium loss is also very high. So just taking plain water may sometimes be counterproductive with hyponatremia. That has to be remembered, particularly also the elderly on diuretics. So having electrolytes in your fluid, I know easier said than done for the poor, but yes, a Nibu Pani with salt, etc., balanced with a plain water alternately probably is a better option than just having plain water, if it's a message for the public.
Yeah, correct, Dr. Sumit. Actually, you rightly mentioned about ensuring the salt balance, and it is probably, I would say, India is accustomed to this heat for centuries together. And some of parts of the India, we take this rice water,
yes,
what you call with salt, pokhada. Yeah, in the state that you from the eastern part of India, and I think in some parts of south also they do take that. So these are the very basic remedies.
Pratibha ma'am, please.
One must remember that heat stroke can happen in the hospital also. The patient may come with something else and may develop heat stroke, where high index of suspicion is a must. If the patient is having continuous fever, not responding to antibiotics, and the air conditioning is not very efficient, then this should also be considered, that the patient could be having on top of his or her earlier illness, could be having additional heat stroke also.
I have to say only two things. One is the very high index of suspicion in heat period, when suddenly temperature soars. If any patient comes to you with a symptom of intractable nausea and altered behavior, before you think anything, start hydrating with saline, normal saline, not with plain water, anything else. There's two things one has to remember, because by hydrating, you are able to prevent a lot of complication. And giving, if somebody is dry, heated, thirsty, giving 1 liter or 2 liter of extra water is not going to do any harm. So one has to, if I have to give one clear message, if you get a patient in this heat time who is having intractable nausea and altered behavior, keep your first diagnosis a high suspicion of heat-related issues. It cannot be heat stroke. It is hypothermia going to heat stroke, and prevent the development of stage 3 of the disease, because stage 3 of disease carry almost 80% mortality, where the role of ECMO and all extracorporeal support come. So let us stop the disease in stage 1 and not allow to progress. That's what I want to say. Family to you.
Yeah, Dr. Singh, Dr.
Singh has probably left.
Okay, thank you. I think thank you very much. We have discussed all in detail. All the panelists have very clearly given a passed out the message, the summary message to our dear friends and colleagues who are attending at this point. And I would like to conclude with saying about our plan of National ICC, the joint venture. The first time we are holding Eurasia in July, from 30th June to 2nd July in Delhi. Dr. Mishra, would you like to talk about it?
Dhaval, can you share the screen about the Eurasia quickly, and then
And thank you, Sharmili, for moderating it so well, and Dr. Mishra.
No, no, sir. I was not moderated. I was assisting.
You are the super moderator.
So I will just again say, request everyone to register for this wonderful event, which is going to happen on 30th June, 1st, 2nd, 3rd July. First of its kind in India, first time. A joint venture of ESISM, ISSM, a residential conference we are planning. So no risk of heat stroke in this conference, despite Delhi is so hot.
Thank you very much.
Thank you.
Thanks,
Thank
everyone.
you all for attending, keeping this late. Thank you all.
Thank you so much. Thank you.
Okay. Thank you.
Thank you, sir. Bye, sir. Good night.